Dear colleagues and friends, esteemed delegates of the World Health Assembly, it's a delight to welcome you to the first multi-stakeholder dialogue on the 2030 Global Agenda for Sepsis that we're convening in parallel to the 77th session of the World Health Assembly. We are honored to partner for the organization of this event with our dear colleagues and strategic players, including Unite Parliamentarians Network for Global Health, Virchow Foundation for Global Health, the Global Antibiotic Research and Development Partnership, Medical Women's International Association, Clinton Health Access Initiative, Sepsis Stiftung, and definitely the Global Sepsis Alliance. It's our third major event co-organized by the partnership of 7 agencies to advance the global agenda for sepsis in view of the immense human and economic impact of this medical emergency and hidden global threat. The overall purpose of our meeting is to present to you the first framework of the 2030 Global Agenda for Sepsis as the first multi-year global strategic plan, how we can reduce the human suffering, healthcare and economic impact and burden of sepsis at global, regional and national levels, and how we can truly reinvigorate the sepsis response for the attainment of better health and well-being of our communities. Without much ado, I would like to invite to the floor Professor Konrad Reinhart, who I believe does not need introduction in the global sepsis community. He has been the champion, the founder of the Global Sepsis Alliance, and the driving force behind all major achievements in the global health agenda, including as the initiator of the World Sepsis Day, the World Sepsis Congresses, as the online platforms currently reaching up to 100,000 stakeholders over the years. And of course, together with dear colleagues from WHO, he has been the initiator of the historic 2017 resolution for sepsis. Even if WHO is not among our formal co-organizing partners, we're immensely grateful to the leadership and partnership with our colleagues from the Department of International Health, Integrated Health Services, Department for Maternal Child Health and Aging, as well as Emergency Preparedness at WHO. And your representation, your amazing support over the months and years has been really an inspiration that together we can make a real difference in the global sepsis response. So thank you. A special thanks to the World Health Organization. Konrad, please.
Thank you, Mariam, for this kind introductions. I think you have a little bit overestimated my role. I was just a coordinator, and many colleagues and friends, and for especially sepsis survivors and their families who have lost their loved ones, have made a great impact that we are here now 7 years after the implementation or the adoption of this WHO sepsis resolution, which was really historic. And I think this meeting today underpins and is another historic milestone in the global fight against sepsis, which is urgently needed, because it's still the case that despite the urge of WHO of this sepsis resolution to the member states, 149 member states, to implement and to make sepsis an integral part of every national healthcare system, has not yet happened. It's far less than 10% of countries who have, by doing so, not implementing it, missed the opportunity to save at least the majority of sepsis patients worldwide, and these are millions, as we know. And we see, and we discussed it already today with some colleagues of WHO, that as long we will not be able to raise awareness on sepsis in the public, by the media, and not increase the understanding of the policymakers on all levels, how bad sepsis is and how many not only human suffering for children, mothers, men, women could be prevented when we would, if the leaderships in this country would have understood and done what in some countries has been demonstrated to be so successful to reduce sepsis mortality and along with this also sepsis sequelae by more than 50%. So, and that's why it's so important that we jointly, and this means all stakeholders, we have from the very beginning had to learn that major health threats are a societal issue which need to involve all parts of the society. And that's why I am so happy that today that we have all stakeholders here. It's not only the health authorities as WHO, it's the foundations like the Virchow Foundation. It's especially that so many parliamentarians have understood this. But also we have the survivors here, we have industry here, because what we had to learn from the success stories in the fight against HIV and cancer, where we have reduced mortalities tremendously. It was only by this joint effort also to improve diagnostics, also to develop novel therapeutics, vaccination, etc., etc. So that's why, thank you so much, and I am really proud that the new leadership that we have already for the GSA and which we will have also in this our case for the German Sepsis Foundation really are so experienced and inspiring that I am very optimistic that after these 7 years, which in some way, despite all our meager years, will now go into 7 years of fat years, to refer to the Bible. Thank you very much for coming.
Thank you so much, Professor Reinhart. Definitely, the fight against sepsis has been led by a multitude of our colleagues, and GSA, the Global Sepsis Alliance, is represented by 4 Regional Sepsis Alliance, 120 member organizations, and currently, in addition to Africa, European, Asia-Pacific, Eastern Mediterranean Regional Sepsis Alliances, as we speak, the Caribbean Sepsis Alliance is taking off. So that's definitely the strength of our partnership and representation. We are just joined by Dr. Rudi Eggers, Director of Integrated Health Services of the World Health Organization. The department led by Dr. Eggers is the primary counterpart of the Global Sepsis Alliance for the sepsis-related work, but we're delighted to see the ever-increasing partnerships with the maternal, newborn child, and the adolescent health and aging department, as well as emergency preparedness department. So again, we really hope for reinvigorated partnership and stronger results jointly. Dr. Eggers, if I can give you the floor for the opening remarks, please.
So good afternoon to you all, and thank you, Dr. Jashi, and your team at the Global Sepsis Alliance. I apologize that I came so late. It's all a big rush around the World Health Assembly, so I'm happy to be here. My name is Rudi Eggers. I'm the Director of Integrated Health Services at the World Health Organization. I've been here for 3 years and have been leading some of the key teams that have been dealing with sepsis in the world. I'd also like to recognize some fellow speakers. Professor Reinhart, of course, well known to all of us. Then Ms. Krista Bracke. I'm not sure if she is present. Pleased to meet you. Thank you so much. And then my fellow director, Dr. Banerjee. And of course, a huge group of experts here in the room representing the different interested parties in sepsis, both in member states and in academia and non-state actors. The WHO Integrated Health Service team has been responding to the 2017 resolution on sepsis, and we have worked very closely with the Global Sepsis Alliance. As Dr. Jashi has said, it's been an ups and downs engagement, but I think just recently we've had much more engagement and much more interest also in taking this forward. However, we also know that also from the gap analysis from the Global Sepsis Alliance done this year, that very few member states, UN member states, actually have prioritized sepsis in their national policies and have in fact implemented the resolution. And that's the reason for an event such as this, really to bring awareness and to highlight some of the key activities around this area of sepsis and accomplishments in the areas of the resolution. So the purpose of this meeting here really is to draw attention on the public health impact of sepsis and the estimated global burden of sepsis. And this is done from WHO side, certainly through items such as the Global Report on Epidemiology and Burden of Sepsis, which was published in 2020. The second purpose of this meeting, of course, is to support member states to define the standards, establish guidelines, infrastructure, laboratory capacities, skills, strategies, and we do that through the WHO processes, of course, of guidelines and direct support. There's a WHO guideline on maternal health, sepsis in young infants, and integrated management of the newborn and childhood illnesses, which also has engagement on maternal sepsis prevention and treatment. Then there's the recent approval of the WHO or the global strategy on infection prevention and control, which was approved at the World Health Assembly last year. And hopefully this year we will have the resultant global action plan on infection prevention and control, hopefully in the next couple of days being approved. There's the guidance on antimicrobial treatment for sepsis and WHO aware. This is an antibiotic book aimed at improving rapid empiric treatment for clinical infections, including sepsis. There's the guidelines for the clinical sepsis management, which will be released stepwise up to December this year. I'm sure we'll hear more about that during the course of this discussion today. The sepsis toolkit was designed to assist countries in system-level planning and evaluation of pathways of care, including specific tools to enable early recognition and timely treatment to improve outcomes. We all know, of course, that that is a critical aspect of sepsis control, is to have that early recognition and treatment. Then we've started on a couple of WHO Academy courses, which include foundation modules on emergency care and critical care, as well as a module dedicated approach to sepsis to be released by the Academy platform by the end of this year. I'm also happy to mention the PAHO, that's the Pan American Health Organization, development of a regional strategy and action plan of sepsis that will be issued soon, probably in the next couple of months. And then the final aspect of this event today is really to collaborate with all of you, with our partners, to enhance sepsis treatment and infection prevention and control, and that includes, of course, vaccinations. Sepsis has been chosen as a flagship work stream within the Acute Care Action Network, or ACAN, which was established a year ago. We've got basic emergency care courses developed by WHO and the International Committee of Red Cross and the International Federation of Emergency Medicines, which trains first contact health workers in the initial approach to serious infection and sepsis, and this has been rolled out in over 90 countries through an extensive partners network. There's also an emergency critical and operative care resolution, which includes key mechanisms for strengthening health systems to respond to sepsis. The Executive Board at the beginning of this year has recommended to the Assembly of the acceptance of this decision, hopefully this week, so that we can move forward in actually establishing this global strategy in the coming years. WHO's ongoing projects and resources for sepsis can be contributing to all 5 pillars of the GSA that GSA has proposed for the 2030 global agenda for sepsis. There's, of course, political leadership and multilateral collaboration, which we are clearly part of, the health system's readiness for sepsis and its sequelae, the whole society response to sepsis, sepsis research and innovation, and sepsis in pandemics and other emergencies. My department's team members will speak around these topics on individual topics shortly in this discussion, and we appreciate and acknowledge and recognize the GSA efforts to include our collaboration of the implementation in this multi-year plan. We will continue to work with you on this going forward and looking forward to good collaboration forward. I'm looking forward to a great program today. I apologize again that I rushed in a bit late. Thank you very much for joining. Thank you.
And thank you enough for your leadership and support for our ongoing and even stronger and more expanded collaboration with WHO, because for truly consolidated and coherent approach to the global health threats, definitely leadership of the World Health Organization is important, and we appreciate. Now I have the pleasure to give the floor to Krista Bracke, our amazing advocate, sepsis survivor from Belgium, a journalist who has been leading and engaged in the fight against sepsis for the last years. And this is the first World Health Assembly as a symbol of our reinvigorated fight, where Krista and Shahrazad Kiavish, our second sepsis survivor, had this unique opportunity of participating in the Walk the Talk Marathon and meeting personally Dr. Tedros. And so we have a beautiful picture symbolizing our mutual collaboration as we move forward. Krista, please.
Thank you very much for inviting me to share my experience. It is of huge importance, I think, to all sepsis survivors everywhere that we get recognition, because not being recognized is, well, I dare not say even worse than sepsis, but at least as worse as. How did I survive sepsis? Let me first begin 2009. I hope this functions. I'm not really good. Yes, indeed. So I used to be a journalist working for the Belgian National Radio until 2009. I had been fighting the symptoms of flu for a day or 4, and then it became worse. It was really a close call. I was infected by the Streptococcus pyogenes bacteria, and followed by multiple organ failure, and I went into a septic shock. But all of this happened really, really fast. I only remember being brought to hospital, and then I tumbled into a coma for about a month and a half. Now, apparently, I've been to or through several cardiac arrests with long-lasting reanimations. And the intensivist at one point said that there was less than 5% chance to survive. And if I would survive, he couldn't predict what the damage would be. There could be mental damage, there could be physical damage, there could be both. I was, well, lucky to survive, but also unfortunate because there was a lot of physical damage. Both of my lower legs, my feet had to be amputated as they were necrotized. There were also problems with both of my hands, especially my right hand. It needed a reconstruction, a very difficult operation which lasted for about 9 hours. And then started the phase of rehabilitation. I learned to walk on 2 prosthetic legs, which is wonderful if you have been sitting in a wheelchair for weeks. But it's also weird because you experience all kinds of things you never have experienced before. A huge pressure, it might lead to pain, but it shouldn't be painful, but because if it's painful, you might have wounds, and wounds means that you have to sit for a while in a wheelchair in order to cure those wounds. And that's why I feel like a tightrope walker. For months, years, it can go good, and I can keep on walking and participating in the walk the talk. But sometimes all of a sudden, like at the beginning of May, I have a blister and I need to spare some time in my wheelchair. Now, at the end of 2009, I also got an extra diagnosis because I've been through 10 pneumonias in 2009. And then the immunologist said, well, your problem is actually that you have a primary immune disorder. You don't produce the IgG2 protein any longer, and this should protect you against mucus encapsulating bacteria. This immune disorder wasn't the cause of the sepsis, he said to me, but it fastened the process, made it more aggressive, more severe. Now, after getting for some time a therapy with antibodies, I could start and try to push my boundaries again. I could swim, I could dance Argentinian tango again, which I loved to do before 2009. I managed to ride the bike again, which was really important because as I became ill, I was a young mom. Our children were 1.5 and 3.5, so I was really fortunate to be able to bring them to school. And then I started running. I was never the sportive type. I had never run before. Actually, I hated running. But my children were participating in the athletics track and the athletics movement in Belgium. And so I had this dream of being able to run one lap around the track with them. And in 2015, finally, I realized. It was really hard, but it gave me so much extra physical and mental strength. And I think due to that extra hard work I had been doing with my physiotherapist, I'm able to stand here now. I'm feeling very confident to do so. Thank you very much. I have also been writing a book about my experiences in Dutch, as I live in the Dutch part of Belgium. It has been translated into French, not yet into English. Who knows what will happen in the future. Now, I didn't realize that I had been through a sepsis. If I look at my file, it is mentioned, Streptococcus pyogenes sepsis. But sepsis, there was no healthcare professional who even pronounced that word to me, let alone explain it. And it was only in 21 when I was asked by somebody to give a testimonial for the Belgian Parliament because we wanted to establish a national sepsis action plan. And then I realized, oh, indeed, I had sepsis as well. And so it was actually 12 years after the diagnosis that I first realized I was also a sepsis survivor. And I'm not really good at technical sides, but I wanted to show you these long-lasting effects which I have from sepsis. And I had been noticing these effects for the past 12 years already, but I didn't realize they were due to sepsis. Effects such as an unpredictable fatigue, extreme fatigue from time to time. I had difficulties in listening to someone, and this is really confronting when you have been working for the radio and listening to and talking was one of the main things in your life. I had concentration problems, which limits me in driving a car, for example, because there are too many impulses at the same time happening. Sometimes I experience word-finding problems, and my short-term memory really is disturbed. My eldest son recently said, "Mom, you have the memory of a goldfish." It's 8 seconds, apparently. Now, these effects, I would like to call them long sepsis, or sometimes they're called post-sepsis syndrome or sequelae or whatever, but I've been experiencing this until now. And some of them have become less, others have become worse. Like these short-term memory disturbance is really sometimes a problem. Now, how did I survive the sepsis? I think it's due to the very alert reaction of the GP's wife, who answered the phone call on the 30th of January 2009 when my mother called to ask for the GP to come to our house to pay us a visit. It was his wife who had the impression that something wasn't right, because it was not Mrs. Bracke herself who made the phone call. Maybe she was so ill she couldn't make that phone call anymore. So that intuition was very important, I think. And also the fact that I was very fortunate that a lot of care professionals took the right decision at the right time. The first person to see me at the department when I arrived in hospital was a cardiologist, and of course he had no scientific proof whatever of what was happening to me, but he saw that my situation was really very bad, and so he gave me a broad spectrum antibiotics. And afterwards the intensivist said that that had really been life-saving. If he had waited, if he had not known about the golden hour for a sepsis patient, then she might have not been able to reanimate me anymore. So I think acting very alert is very important to save the quality of life for patients and limit the consequences. I would like to give you some take-home messages. I think it's, well, maybe 12:05. We should really have an action plan on a global level. And we should try and increase overall awareness of sepsis, as 80% of sepsis occurs outside hospital, and people, to my experience, do not really know what sepsis is about. We should also educate healthcare professionals, especially at the emergency department and primary care, because way too often patients arrive at the emergency, they're complaining about feeling very, very terrible. They had the impression they're going to die, they're in agony, and they're sent home with a painkiller because maybe, well, they have stress or they're depressed. That's what they hear the healthcare professionals saying. And of course, we should also invest in the aftercare for long sepsis patients and stimulate more multidisciplinary research. And I think that test results, if we have them, they must also lead to prompt action within 1 hour after the diagnosis, but the results only are not enough. They must be communicated to the people on the departments, to the clinical professionals. And I'd like to end with a quote from Professor Mervyn Singer from the University College of London, who said on the symposium in Paris that laboratory and clinical people on the bedside should work together and deliver a 24-hour service. Let's fight together against sepsis, because together we're stronger. Thank you very much.
Krista, thank you so much. You know, after your testimonial, it's really difficult to go back to the discussions, because you know the best what it means from the patient's perspective, from the importance of early recognition and intervention. So, and I'm really grateful that you're standing with us and really fight in this fight together. And just to note that Krista in September will be hosting the first European Patients Forum for Sepsis, and this could be together with GSA and the European Sepsis Alliance, and we hope for reinvigorating the voice of patients also at the European level. So thank you for your leadership and thank you for your presentation. And now I have the pleasure of inviting Dr. Anshu Banerjee, the Director of Department of Maternal, Newborn, Child and Adolescent Health and Aging at the World Health Organization. I finally made the name of the department right. And in view of the burden of maternal and child and neonatal health and sepsis burden among newborns and the women going through pregnancy and childbirth, of course, your department is one of the key counterparts and stakeholders, and please, we're honored to have you at the.
Thank you very much. It's a pleasure to be here, and I'd like to complement a little bit what Rudi has been highlighting, because as just mentioned, our department is contributing to the work around sepsis, but looking at, let's say, the children under 2 months of age and how we're taking care of that. So, I mean, the vulnerable populations for sepsis are basically neonates, pregnant women, infants, older people, all population groups that our department covers, but also, of course, hospitalized patients as well as immunocompromised patients. But a number of the common infections are leading to, let's say, sepsis. And so it could be a skin infection in children. It could be a lower tract infection, a respiratory tract infection. It could be a urinary tract infection. And so these are infections that could result in sepsis but are preventable. And so I think, prevention is better than cure. And if we are able to, through a primary healthcare approach, identify, diagnose these cases first and treat them with antibiotics so that they don't continue to develop into more serious complications, the better. And so I think one point really to make is really how do we strengthen primary healthcare, an issue that Rudi's department is also very much involved in, and how do we make sure that we can diagnose early, that we have the medications in place for first-line treatment, and that we have proper tests to do so. So at the same time also, of course, many infections are hospital-acquired, and so 1 in 4 cases are hospital-acquired, and this leads then also to longer-term management, longer stay in hospital, more expensive antibiotics, and results in increase in cost. So again, how can we have primary prevention in place, such as hand washing, safe preparation of food, improved availability of sanitation and water, but also vaccination plays an important role. And we have another department that really deals with immunization and immunization of children, but also across the life course, but also appropriate nutrition, breastfeeding for newborns, infection prevention and control, as was already mentioned, and effective hygiene practices and precautions in order to prevent infections and potentially later on secondary sepsis to that. And of course also when it comes to prevention, to really look at prompt recognition, care seeking, and early diagnosis. We just heard about the issue of intuition, and if that hadn't been there, that prompt recognition wouldn't have been there. So maybe just to highlight a few things that our department is doing and complementing the Integrated Health Services Department. Our department conducts also quite some research, and so we are conducting multi-country trials looking at what would be the optimal place of treatment and duration of inpatient treatment for infants less than 2 months old with a potential possible severe bacterial infection, as well as looking at what would be, how can we improve treatment coverage for these children less than 2 years old with suspected possible severe bacterial infection. The other thing that we've done is we have recently updated our guidelines on management of young infants less than 2 months old with serious bacterial infections at hospital and primary healthcare settings. And we also launched recently the WHO recommendations for care of the preterm or low birth weight infants. On children above 2 months old, we work jointly with the Integrated Health Services Department. And one thing that we're looking at the moment is, and this is in collaboration with the AMR department, Antimicrobial Resistance Department, is to develop a target product profile for neonatal sepsis tests, both for screening and for diagnosis. Because diagnosis, the earlier, the better we can diagnose, the better we can manage the cases. And so it's important that we have better diagnostic tools to help us take this forward. Thank you very much.
Thank you, Dr. Banerjee. And again, the burden of sepsis in children and women are especially alarming. So this critical collaboration with your department and the integrated collaboration with other fellow departments would be extremely important. And again, our gratitude and appreciation of your work and being with us today. Now I have the honor and pleasure of presenting the results of our work, starting from the very initial strategic discussions last year in New York. with the members of the Global Sepsis Alliance, the partners of the Global Sepsis Alliance, and the multiple stakeholders from public, private, civil society, and academia sectors. The 2030 Global Agenda for Sepsis, I hope we have the presentation ready. Yes, thank you. Wonderful. So the 2030 Global Agenda for Sepsis is the first multi-year global strategy for sepsis. It's a GSA-led strategic planning process that will be inclusive and has been inclusive of different multiple stakeholders, and it will form the common platform of partnership and resource mobilization. Of course, ideally, this process would have been led by the UN member states, but considering the urgency of action and the timelines required for the government-led processes, we believe that it would be more helpful and time-effective to bring the discussions and the perspectives from multiple stakeholders into the document that will be currently led by the Global Sepsis Alliance. But of course, we are ready to translate this process into more formal government-led processes at WHO. The timelines of the strategic planning process is that from March to May, we have drafted this framework. We already presented the framework at the World Sepsis Congress, attended by 12,000 participants from 180 countries, and where we had the pleasure and honor of a very special address by Dr. Tedros, the Director General of WHO, and he highlighted a very important and powerful message that no one should die from sepsis, because sepsis is primarily preventable, and with early identification and treatment, we definitely can avert the preventable deaths. In June and August, we will continue in discussing, based on this framework, we are already developing a full narrative document of the multi-year strategy. And in June and August, we will be presenting the document for wider consultation with partners, both online and face-to-face opportunities. And the plan is to launch the first multi-year strategy for sepsis on September 13, the World Sepsis Day in Berlin, and follow with formal presentations on the margins of the UN General Assembly and high-level meeting on AMR, and then the World Health Summit and UNITE joint summits in October, again in Germany. So the document will consolidate 4 major sections, consolidating the global burden of sepsis, including human, social, health sector and economic burden. It will consolidate the 2 decades of fight against sepsis and the major achievements, including the knowledge evolution and clinical management of sepsis, global advocacy for sepsis, as well as the success stories from different countries. Unfortunately, most of these success stories are coming from high-income countries, but again, this is already a step forward, and we have to concentrate on both data generation and implementation science from low and middle-income countries, especially considering that 80% of the sepsis burden is in resource-limited settings. The document will consolidate the existing response gaps at the policy, institutional, community, monitoring and evaluation, and research and development fronts, as well as the way forward, the 5 pillars that Dr. Eggers has summarized in the introduction, how we can truly reduce the human and economic burden of sepsis. The document will build on the foundational platforms in global advocacy, the 2017 World Health Assembly resolution on sepsis adopted 7 years ago, as well as the foundational first global burden of sepsis study and publication in Lancet in 2020, followed by the first WHO global report on sepsis the same year, G7 health ministers communique under the presidency of Germany, where sepsis was integrated into the final outcome document of G7 ministries, and the Berlin Declaration of Sepsis that we adopted last year and that is currently signed by 75 international health partners. The key in the future agenda of sepsis is that without reinvigorated sepsis response, it would be impossible to attain aspirational targets of Sustainable Development Goals, universal health coverage, AMR, and the pandemic accord. And the document will also provide evidence, consolidate evidence, why this is true. So starting with the Sustainable Development Goals, of course, naturally, sepsis has the biggest impact on the possibility and potential of attaining the third Sustainable Development Goals. With 48.9, almost 50 million cases globally every year, including 5.7 million pregnant women affected by sepsis, 20 million children under age of 5 affected by sepsis every year, sepsis causing more than 10% of maternal deaths, 2.9 million under 5 child deaths every year, and in contrary to the common understanding that sepsis is primarily related to infectious diseases, in more than 5 million cases, sepsis has been the result of the secondary infectious complications of non-communicable diseases and injuries. So we have the whole span of health-related SDGs related to sepsis. In addition, when we speak about the AMR agenda, it's delightful to see the current momentum on the global political leadership on AMR. And everyone knows that up to 5 million deaths is associated or attributed to antimicrobial resistance. But very few politicians, very few global health leaders speak about the fact that these 5 million deaths are part of the 13 million sepsis-related deaths. So while we speak on AMR, we cannot continue the status quo of not speaking about sepsis as the umbrella challenge of the antimicrobial resistance. And these two figures originate from the same source, the Institute of Health Metrics and Evaluation. Sepsis is also related to 6 other Sustainable Development Goals. We have evidence from multiple studies that poverty increases the risk of sepsis and sepsis-related mortality. More women are affected by sepsis than men, so we have the gender inequality issue with 26 million women versus 22 million men affected every year. Water and sanitation, of course, with the current reality that 1/4 of health care institutions do not have basic water and sanitation facilities, how we can prevent the millions of preventable infections, diseases. Reduced inequality, 85% of sepsis burden is in low and middle income country, and poor are affected the most. Climate change. There is the multi-country and the multitude of countries indicate in direct correlation of climate change effects on the increased risks of infections. And one of the studies led by Mora et al. Says that the climate change has an impact as potential to exaggerate 58% of 375 known human pathogens. Every infection disease has a risk of increasing sepsis incidence and mortality. So climate change is definitely something that we have to work through. And of course, partnerships for goals through national policies, official development assistance, research and development, and accountability of national governments. Economic and health burden of sepsis. The best available kind of multi-country study indicates that average cost per sepsis patient is 36,000 euro. $26,000 for the severe pediatric sepsis hospitalization, 12 times higher than for any other standard hospitalization from the US colleagues. 2.65% of healthcare budget expenditures are related to sepsis response. That corresponds to 0.33% of the gross national products. Those figures are huge in terms of economic impact of the countries, and they also indicate the potential, what we can save not only in terms of lives and human suffering elevation, but the longer-term socio-economic development of the countries. Sepsis also bears significant indirect society costs. In fact, from 70 to 80% of the total cost of sepsis are due to loss of productivity, and Krista's testimonial was a clear indication of that challenge. We see diminished productivity after sepsis in 53% of patients, and after 1 year of sepsis episodes, both in Netherlands and United States and other countries, from 47 to 49% of sepsis survivors are unemployed first time after the sepsis episode. So again, we're speaking about immense losses in terms of financial and economic burden. So based on the analysis, the Global Sepsis Alliance, based on the consultations and feedback from different stakeholders, we are proposing the 2030 Global Agenda for Sepsis to include 5 strategic pillars: political leadership and multilateral cooperation, the health system readiness pillar for prevention, early identification, and treatment, whole of society approach, research and innovations, and sepsis in emergencies. And very briefly, let us give you the highlights of each of the direction. So under the political leadership and multilateral cooperation, sepsis should be in the mainstream of the global health architecture. With this level of human and economic burden, it's surprising that sepsis is not talked about in every single forum. The G7, G20, the World Health Assembly, UNGA, and related ministerial summits. So this is the momentum that we definitely have to use. Second, based on the World Health Assembly resolution, we have to ensure that countries increasingly develop and implement national action plans for sepsis. But it is not necessary to have standalone sepsis plans. As far as sepsis is integrated into the holistic health sector policies and strategies, it is sufficient to ensure relevant national response. But as of today, less than 10% of UN member states, less than 20 countries have prioritized sepsis in their national plans. And we shall also request for establishment of the National Sepsis Alliances as the coordination mechanism led by ministers of health and bringing together multiple stakeholders, similar to the success stories of immunization, HIV, TB, and malaria. We shall synergize sepsis response with other Sustainable Development Goals agenda, including universal health coverage, MNCH, infections prevention and control, AMR, patient safety, quality improvement initiatives. Multilateralism and funding. We don't have any funding for sepsis, or if we have, those are only exceptions to the general rule. We have to ensure funding both from the domestic budgetary resources as well as create multilateral funding in the official development assistance, potentially integrating sepsis-related funding in the Gavi and Global Fund health system strengthening portfolios, and increasingly discussing possibility of innovative funding from UNITAID and other sources. Global monitoring and accountability will be an important element of the political leadership because till today, the data is very limited. We don't have real data monitoring possibilities at the national level. So we have to improve both quantity and quality of data and regular global sepsis reports. Health system strengthening and readiness for sepsis shall prioritize development of evidence-based and patient-focused protocols, the clinical pathways and bundles for sepsis, similar to the United Kingdom, US, Sweden, Australia, and some other country experiences. Rapid response system should be also aligned with the national clinical pathways and bundles. Equipment and supplies for sepsis, starting from microbiology labs, rapid diagnostics, ventilators, including oxygen supplementation, renal replacement therapies, patient monitoring, antibiotics, and other supplies should be guaranteed at the relevant healthcare settings. Maternal, neonatal, and child health should have special focus in the health system readiness initiatives for sepsis. A focus on perinatal care for safe childbirth and low and middle income countries, especially sub-Saharan Africa and Southeast Asia, with the highest burden of maternal and neonatal sepsis. Medical education and training would be an important aspect of the health system strengthening, including integration of sepsis in undergraduate education, postgraduate CME systems, and focusing on active learning, digital and telemedicine opportunities, because we have evidence that those approaches matter and improve both knowledge and the skills of healthcare professionals. And finally, sepsis care quality improvement initiatives. Dr. Banerjee talked about the primary health care levels and the importance of the primary health care. We have to increasingly discuss regionalization of the critical care and the sepsis management from primary up to comprehensive sepsis care centers, and potential of accreditation, either sepsis-specific modules or integrated into the patient safety, IPC, and other modules. Under the health system strengthening, of course, we have to reinforce efforts for immunization, water and sanitation and hand hygiene practices, and antimicrobial stewardship. So those cross-cutting priorities should be equally kind of foreseen and implemented. Whole of society approach, sepsis prevention in communities, again starting with routine vaccination and seasonal or campaign vaccination programs, hand hygiene practices, health education. We have to ensure that societies identify sepsis as a medical emergency. We identify heart attacks as emergency, medical emergency, but not sepsis. So increasingly, we have to invest in education that time-sensitive response matters during the sepsis cases. Engaging public leaders and media through the World Sepsis Day movement, context-tailored sepsis campaigns and toolkits, and patients for patients care continuum, both post-discharge and the early alert systems for sepsis identification in the community level. The fourth pillar, sepsis research and innovation, will call for increased funding in research, both from public and private sources, similar to the experience of BARDA from the United States and STARS initiative funded by Germany to create data from sub-Saharan Africa. Academic cooperation and knowledge hubs for sepsis, similar to the Sepsis Stiftung Sepsis Information Center and the initiative of George Institute for Global Health in Australia. And of course, sepsis innovations in research and development. We have to prioritize both novel vaccines against the pathogens as the leading causes of sepsis, diagnostics, biomarkers, molecular fingerprints, point-of-care diagnostics possibilities, antimicrobial and immunotherapies, and we're speaking not only about antibiotic, but antifungal, antiviral, antiparasitic medications, and artificial intelligence tools, because increasingly we have potential of early alert systems, but the existing tools today have very high false positive results. So improving specificity and sensitivity of those tools will matter. And finally, sepsis in emergencies. Sepsis in pandemics. 78% of ICU patients with COVID had sepsis, and we never spoke about it. So any future pandemic will increase the risk of sepsis, so we have to be prepared better. Sepsis in armed conflicts. With the ongoing humanitarian crisis and conflicts around the world, the soldiers, the frontline kind of fighters, and also the humanitarian workers are at increased risk of injuries and related infection and sepsis complications. So we have to work not only with the Ministries of Health, but the Ministries of Defense and peacekeeping forces. Sepsis in humanitarian crisis, displaced populations would be related interventions. We have to integrate sepsis guidance in relevant humanitarian aid tools. And climate change and sepsis, again, advocacy and recommendations on the increased risks of infectious diseases and sepsis. So with this, I'm delighted to conclude this brief presentation of the framework. Based on your feedback, we will update the framework, and in June, we'll share the narrative draft for your comments, so we can all finalize the document for the September official launch. Thank you very much. So with this, we will start the moderated discussions, the second part of our meeting. And I have the immense honor and pleasure to invite my dearest friend and colleague, very well-known global health leader, Dr. Ricardo Baptista Leite, the president of the Unite Parliamentarians Network for Global Health and the CEO of the Health AI Agency. Ricardo.
Thank you. Well, thank you so much, Mariam. It's a real pleasure to be here, and thank you for your leadership also. And I'll get to you in a second when talking about Unite. I also want to thank Konrad and everyone really at the team pushing for the sepsis agenda, as you've been doing for so many years now. And this is something that I think has started to see the transformative impact, and amazing stories like we heard here are the ones that really make us gain hope. And if I could get my presentation up there. The technical colleagues forgot about me, but it's great to be here, and I'm here representing the Unite Parliamentarians Network for Global Health, which is really a network of current and former parliamentarians. We are around 500 members from now 112 countries, and that's how my relationship started with Mariam Jashi, precisely, and given her role also as a former member of parliament and now as a member of our board, one of the founding members of our board, and a chapter chair for Eastern Europe and Central Asia. So my presentation is very short, as the statement was requested, and focusing precisely on hope. And at Unite, we're trying to build that generation of political leaders. We work with the World Health Organization and in direct partnership, trying to promote science-based policy making. It's one of those things that one thinks wouldn't need a lot of advocacy for, using science for policy making. Believe me, it's become a thing. And a lot of people are questioning science when it comes to policy. And we are around the world, so we've divided the world into 10 chapters. Each chapter has a current or former parliamentarian as a chapter chair, and that forms the board, along with our secretariat that has offices around 6 different countries. And most recently, talking about parliaments, it became very well known in the news. We were just talking about this, Mariam, of how Honorable Craig has lost his 4 limbs precisely in a case of sepsis, and was welcomed in the House of Commons as a case really demonstrating and putting sepsis on the agenda. And Konrad and I were just speaking at the beginning on how in the past probably he would appear, he would be praised as he was, but the word sepsis would never have been mentioned, because in reality, in the past, many people would not even understand the concept. We still have a long way to go, and we know that, but it means that something is changing, and that is a positive, because you can only change what you know. And I think that is extremely important. And so speaking about sepsis and parliamentarians, I think there are many things that at the parliamentarian level one can do, picking up precisely on the agenda that Mariam presented here and the framework that was presented, thinking about how national action plans need to be incorporated in many countries. We still have many countries that do not have specific actions. We saw how at the multilateral level, the AMR high-level meeting that is coming up at UNGA, very grateful that both Mariam, but also our chapter chair for North America, Sonia Sidhu, the honorable member from Canada, spoke up at the hearing last month, or this month, in preparation of the high-level meeting. But also Unite is highly engaged in replenishment of a series of multilateral organizations involved in this, making sure that the money is getting where it's needed through budgets. So parliamentarians are responsible for laws, policies, but also resource allocation, and this is a critical element, but also ensuring investment in research and development. And artificial intelligence, of course, needs to be part of that. I would add to what you were saying on prevention and on sentinel surveillance, also in terms of the acceleration of drug development, where artificial intelligence has the potential of lowering costs and accelerating access to patients. Just a couple words to say that Unite is putting together its Unite Global Summit in partnership, and Carsten is speaking today in partner. We're very proud to be partnering with the World Health Summit in Berlin. So if you're going to the World Health Summit, if you're not going, you have to go. So that's the first message for Carsten. The second thing is stay an extra day. And so the evening of the last day of the World Health Summit will be on the rooftop of the Bundestag, followed by a full day with parliamentarians. So normally you run away from politicians. In this case, I'm encouraging you to meet them because these are true global health champions that will be convening in Berlin to push the agenda. One last word to end. My personal experience, I'm a physician trained in infectious diseases. That was my first life. And in the parliamentary recess of 2021, during the first summer after the Russian invasion of Ukraine, I decided to volunteer as a medical doctor in the Lviv Regional Hospital. And they basically put me working for most of the time here in this bunker underground, which was the neonatal intensive care unit. It's underground because every time the alarms go off, you can't get the incubators up and down stairs. My T-shirt was glued to my body after 1 hour down in the bunker. These people, mostly women healthcare workers, have been working there now for years. And that's the conditions they're working in. But they fortunately have technology that mostly was provisioned by the government of Poland and is allowing them to respond. And there has been a surge of premature babies because of lack of pregnancy care. And in the context of the war, obviously. And that's where I met Milana, a premature baby born at 7 months gestation with severe sepsis. Her brother died at birth. She survived, but 700 grams of weight here and doing a multiple course of antibiotics. Nobody really believed that she would survive sepsis. And so a few weeks passed. My last day on the job, I was able to welcome a group of nearly 100 medical doctors to start working. They had finished university, a lot of women doctors for your association, Mariam. And we see here that all of them decided to stay in Ukraine because they didn't want to leave. And before I left, I wanted to go see Milana one last time. And when I got there, she was already in her mother's arms. She was still doing antibiotic, but already with over a kilo at this stage, and a bit more promising. And I can tell you every 6 months, I get a picture, and you can see that she has survived. And that shows us that she was lucky, but we can do this for many more people if we are capable of putting sepsis right top of that agenda, of making sure that we get this right, making sure that the Alliance's framework is put into practice, and you have the absolute commitment of the Unite Parliamentarians Network to do exactly that. Thank you very much.
Ricardo, you never stop surprising and inspiring us. Thank you so much. That was exactly the picture and photo of hope that we want to bring for millions of children and their mothers. And it also cross-cuts with the different areas we spoke about, both maternal and child health and emergency readiness. So thank you so much for this wonderful intervention. Now I have the pleasure to invite Carsten Schicker, CEO of the Managing Director of the World Health Summit. It's an honor to have you, Carsten. And again, let us hear what you think about the 2030 Global Agenda and our potential collaboration.
Thanks for having me. Ladies and gentlemen, distinguished guests, it's really an honor for me to address you here at this esteemed gathering. And I especially want to thank you, Ms. Bracke, for sharing your story of strength. You're really a beacon of hope, and I appreciate that you share your story so openly with us. Thank you so much. So as we have learned, sepsis is a medical emergency, but it is often under-recognized and misperceived, and it affects 50 million people worldwide. But I feel that the awareness and understanding of sepsis both among healthcare workers and among the broader community is not where it should actually be. So from my perspective, education is really key to address or to fight sepsis overall. To combat this silent killer, we must prioritize comprehensive education and training for healthcare professionals. And you laid out that we need to come to evidence-based protocols and rapid response systems. They must become standard practice in healthcare settings worldwide. However, I believe education should not be confined to healthcare providers alone. We must extend our efforts to the broader community. Public awareness campaigns are crucial in that effort and to really demystify sepsis. A condition that, for example, in my home country, Germany, is still called and thus misperceived as blood poisoning among the wider population. So I think we need to make an effort to educate the broader community what sepsis really is, and that is really a medical emergency. You laid out your strategy, and I think it's very comprehensive. You laid out that political leadership, health system readiness, a whole of society approach, research and innovation are key, and addressing sepsis also in emergencies. So each pillar is, of course, important, but I want to stress the importance of two pillars in particular, and that is political leadership and multilateral cooperation, as well as the whole society approach. So a forum like the World Health Summit plays a pivotal role in raising awareness and putting the topic of sepsis on the political agenda. Through our platform, and we bring together stakeholders from politics, civil society, the private sector, and academia to set the agenda for a healthier future. Through our platform, we can really put sepsis on the political agenda again, and we are very committed to doing that again. So the fight against sepsis has been featured at the World Health Summit multiple times, last time in 2022 with a session in the main program, and it will certainly be a key topic, especially around the discussions on AMR that will be happening in Berlin this October. So I believe equally important as the political agenda is the whole of society approach you laid out. That involves engaging communities, raising awareness, as I said, and fostering partnerships that drive innovation and research. And again, the World Health Summit is the ideal forum. It has a global reach across all sectors of society, beyond just the academic community and politics, and I believe we can be instrumental in that mission. So let's remember that sepsis is not just a medical issue, it's a societal challenge. And by educating healthcare workers and the broader public, raising awareness, fostering political will, and leveraging innovative research, I believe we can move closer to a world that is free of sepsis. Thank you so much.
Thank you so much. Carsten, we couldn't ask for a better kind of commitment and feedback to the 2030 agenda, and we look forward to discussing how we can strongly position sepsis in the upcoming summit. We do have definitely the commitment of Unite Parliamentarians Network also to highlight the synergies between sepsis and AMR agenda. Now it's my pleasure to present Professor Benedetta Allegranzi, Unit Head of Infectious Prevention and Control at the World Health Organization and our dear colleague and committed partner for sepsis.
So thanks a lot, Mariam, and good afternoon, everyone. It's a difficult task to continue this conversation after such great speakers. As Mariam said, I'm the head of infection prevention and control in the Integrated Health Services Department at WHO, and our unit has the task of coordinating the work of sepsis at WHO. And we were those working with the Global Sepsis Alliance to develop the resolution together with member states years ago. So, as you know, the resolution I identified 4 main pillars, which are the epidemiology and burden of sepsis, prevention, diagnosis, and clinical management. Our unit is in charge of the work of WHO on epidemiology and prevention, together with others as well, with which we coordinate. So today, I just wanted to highlight a couple of points on these two areas which we work on, epidemiology, burden, and then prevention. So I'm not going to talk about data because I knew that Mariam was going to give this terrific presentation, really summarizing very well key data on sepsis and its consequences. But, and as you heard, WHO has issued a first ever global report in 2020, and also IHME did that very important global sepsis study to help us with this data. At the time, we reflected a lot on the gaps in this field, and in particular, issues were identified in not having standardized definitions for sepsis in different patient populations, also countries not having real systems for surveillance of sepsis, both in the community and also in healthcare. And the most important point was really the almost absence of data from low middle income countries. So I'm sorry to say that many of these gaps continue, but of course we have also improved. From our side, we are about to issue new simplified surveillance definitions for healthcare-associated infections in low-resource settings, which include one definition which is based on sepsis. And also, I would like to remind you that surveillance and diagnostic stewardship is one of the pillars of the new people-centered strategy to reduce AMR in human health that WHO just issued recently. So I think we are on the right track, but we also need a lot of help and work with countries on this particular issue, and also work with other organizations, the Sepsis Alliance, to use data for advocacy. And I would like to highlight Mariam's point on economic data, cost-effectiveness data, because this is one of the ways to buy in with the politicians, which play an important role, as we have been reminded just now. So these are key directions where we want to go in terms of epidemiology and burden work. And of course, the burden work is also super important to translate it into action at the country level, because only when you know what is your problem, you can develop consequent global action plans. The second point, of course, is prevention. And as you know, in prevention of sepsis, we have two main pillars: prevention of infection and prevention of the evolution of infection to sepsis. So again, I think there have been many progresses over the last few years in terms of awareness of infection prevention and control, national work and campaigns, new guidelines. We just issued the guidelines for the prevention of bloodstream infections due to peripheral catheters. We are we are starting the work on CLABSI, the central line infection prevention. And you heard about also the clinical management guidelines. But again, in prevention, still many gaps still exist. I would like to highlight three: the need for strengthening WASH, water and sanitation, and hygiene. Let's remember that worldwide, 2.2 billion people still lack access to safe drinking water, and 2 billion people do not have access to hand washing facilities in the community. And then importantly, 1 in 4 healthcare facilities lack basic water, and 1 in 2 healthcare facilities lack hand hygiene at the point of care. So we need to certainly push for the real implementation of WASH. Second point also, despite of the many progresses in vaccination worldwide, we still have to improve the prevention through vaccination of specific bacterial infections in vulnerable populations, such as the pneumococcal vaccination for elderly people, or meningococcal, very simple, meningococcal vaccination in neonates and in children in high-risk areas. And the last point, as we said, the importance of preventing the evolution of an infection to sepsis and the crucial role of point-of-care diagnostics in order to make early diagnosis and early treatment, like Krista just told us in her experience, happened. So I think that overall, in terms of our effort, we really need to bear in mind the focus on low middle-income countries and low-resource settings, use of very simple interventions such as hand hygiene, both in the community and in healthcare. We just had some new data on hand hygiene impact in terms of cost saving in healthcare, where OECD found that by investing $1, you save $24.6. So we are totally aligned with the global agenda. We would like to contribute to it. And we hope we can further expand to new areas of work together. And we really wish you the very best with this global agenda. Thank you so much.
Benedetta, thank you. I think this is the statement that we can only kind of look forward to, and we're sure that as you have been leading our continuous partnership and supporting the visibility of the sepsis survivors over the last couple of days within the current assembly and over the years in partnership with Professor Konrad, Reinhart, and others, we really hope for this strong and continued collaboration. Much appreciated. Thank you. We have a wonderful, like a stardom of speakers. We understand that, time-wise, we would be expanding the meeting. We're not closing the meeting. We will continue to hear every single intervention as proposed by the different partners. And we also understand that because of the ongoing assembly, some of our speakers may need to leave. And of course, this is understandable. And thank you again for being with us. Let me now give the floor to Victoria Grandsoult, who is representing Roland Goede, who unfortunately couldn't come to the assembly in person today, the CEO and co-founder of the Virchow Foundation for Global Health. But we have his excellent ambassador, Victoria, who is the managing director of the Virchow Foundation for Global Health. As you know, this is the Nobel Prize in Global Health. So, please.
Thank you so much for hosting, and of course, always to the Global Sepsis Alliance and to all the partners here for making this happen. And as Mariam said, I'm here representing my colleague, Roland. I'm the managing director of the Virchow Foundation for Global Health, so thank you so much. And the Virchow Foundation was founded in 2021 in Berlin. It was founded to raise awareness for global health and the attainment of the United Nations Sustainable Development Goals. We're based in Berlin, and our key initiative for this raising awareness is the awarding of the Virchow Prize for Global Health, which Mariam so kindly called the Nobel Prize. We certainly strive to reach this level of prestige. It's a highly endowed prize, which is awarded annually in Berlin City Hall. And although there was a pitch earlier from Ricardo and the World Health Summit colleagues are here, that they will take place on the 13th through 16th of October, our award ceremony will actually take place the day before. So I would even encourage to come one day earlier for a nice long week in Berlin for global health. And so again, that will take place in City Hall on October 12th. And so much like the discussions that have taken place today for sepsis, I mean, the mission and vision of the Virchow Prize is to really give a face to global health and recognize the broad achievements of global health in connection with the United Nations Sustainable Development Goals and how we can elevate and give a platform for these champions on the ground and hear their stories. And so The Virchow Foundation has been a proud partner of the Global Sepsis Alliance since our beginning, which was not so many years ago. But this began at the GSA Congress that Mariam also introduced earlier, that was held earlier this year in New York. And at this meeting, the first Virchow Prize winner, John Nkengason, gave the keynote intervention in which he shared his experience as the founding director of the Africa CDC and as current ambassador for global health in the United States, overseeing the Emergency Plan for AIDS, PEPFAR, in the United States, and how HIV pandemic has really shaped global health. I think what we've really heard today, and with the different frameworks that have been provided, that sepsis also really needs to shape global health and is, and how important it is to continue keeping it on the political agenda, in the community agenda, and engaging as much as possible to advance these initiatives or these milestones. And so as a local partner in Berlin, the Virchow Foundation congratulates the Global Sepsis Alliance on the upcoming Berlin Declaration on Sepsis. We will continue to engage local and international partners on the urgent need to alleviate the burden of sepsis and our common mission on achieving SDG 3 and the 2030 agenda. I mean, I can only say, as an organization that isn't working directly in sepsis, but is working for SDG 3 and how it links to the other SDGs, increasing our education, as Carsten said, and so we can then share this education with our other partners and just mobilize the movement to alleviate sepsis. I mean, we have our commitment for this, and thank you so much for letting me speak today, and congratulations.
Victoria, we are the ones to be grateful to the Virchow Foundation. And again, we see that under the strategic pillar 1, we have the support of some of the key global health leaders for the political advocacy, and delightful to have Virchow Foundation among our key strategic partners. Thank you. Now I have the pleasure of inviting Dr. Teri Reynolds, Unit Head of Clinical Services and Systems, Technical Lead of Acute Care Action Network for WHO, who is leading the ongoing historic work on the clinical management of sepsis guidelines.
Thank you very much. And Marvin, if you could pull up the slides, that would be great. So I am also in Rudi's team, and we complement the work that Benedetta's team does on prevention and epidemiology. And we work on the care of sepsis. And prevention is definitely better than care. That said, we would never write off a generation suffering from heart disease or HIV or a road traffic crash just because we would rather prevent them. So we have an extraordinary opportunity to save lives through care as well. Krista Bracke, I wanted to thank you for your intervention, because not only is it very powerful that you're sharing your personal story, it is also, by the way, one of the best technical overviews I've heard of exactly what health systems need to do in order to respond to sepsis. What I mean by that is, Krista said 80% is manifesting outside of hospitals. We need pathways. We need to be alert, so we need early recognition at every level of the system. We need to support both communities, individuals, and health workers to make, quote, the right decision at the right time. We need timely therapy based on clinical presentations, not only waiting for testing. And when we have testing, we have to remember that it means nothing without interpretation and action. So since she's already given my presentation, I'm going to flip you through a couple of things very quickly. We work to achieve these things on 3 levels: at the packages and planning level, at the pathways level, and then finally at the level of the clinical encounter itself. And I'm just going to show you what that looks like in a couple things. This is our WHO service planning platform. A lot of countries start with packages of essential health services or priority services for UHC. This is one of the most powerful ways to change the world, is through this UHC agenda. So what we have done is made sure that some of the presentations like shock, but also dedicated services for sepsis, are available on this planning platform so that countries will include them in the services that they prioritize and that they therefore preferentially direct public funds towards, that they use to build their health worker competencies, that they use to procure the equipment and supplies they need. What you see here is planning across levels of the system. You want IV fluids everywhere, but maybe vasopressors you can only deliver at a higher level. So this is what do you need where to respond appropriately to sepsis. If you were to open each of those little services, it's connected to the WHO Essential Medicines list and the Medivis database, the devices database, to show you the equipment and supplies that you need, as well as the health workforce needs for that. This is another way. So that's policy, packages, and planning. This is pathways. So this is somewhere in the middle. This is a tool that helps you look to see is your health system able to deliver every one of the functions that Krista outlined, for example? If it's not, what is your barrier? And if you have a barrier, what action would you like to take? So importantly, these are the steps countries take, but the output of this, if you look, is not an assessment, but it's an action plan of actions that are specified to a given context. And as you see, there's a dedicated sepsis pathway, injury, but there's also the high-risk pathogens, the emergency events and hazards, and in this case, a couple that may be associated with sepsis. And then finally, at the level of delivery, because we can achieve reductions of around 50% of mortality with simple process changes and training on early recognition on how to be alert at every level of the system. At first level hospitals, we've seen evidence showing we can reduce mortality by 50% with simple, affordable changes that do not require new input of material resources and that can be done in any country. So that's why I say prevention is most definitely better, but we should not write off care. This is the last slide. We have two ways of manifesting these activities. One is the Acute Care Action Network, which several of you are engaged in already. Sepsis is a flagship within the Acute Care Action Network. So it will have its first convening in October, and we will be working on sepsis as a priority for the next 2 years. There's information there, that code. And then this is the Clinical Care for Sepsis page. We're responsible for the guidance on the clinical care of sepsis. And we'll start putting out modules of that stepwise, starting at the end of this year in December. And Emily Calvello from my team is here also and is our main focal point on that. So thank you very much. It's lovely to be with you.
Teri, thank you so much for your dedication and incredible wealth of information and the work that you and your team are leading. And coming from the UNICEF and the government perspective, knowing how important WHO guidelines are for scaling up implementation in the field, definitely this could be the landmark and another step in history for sepsis management. Thank you. Unfortunately, David Repin, our dear friend and colleague from the Clinton Health Access Initiative, he had to replace the CEO because of the logistics challenges at the World Health Assembly, but David will join us as soon as possible. And let me give the floor to Dr. Janet Diaz, our lead of Clinical Management Operations Unit of the WHO, another department of WHO working with us.
All right. Good afternoon, colleagues. It is my pleasure to be here, and thank you. I'm privileged to first just meet Mariam for the first time, so it's nice to see new colleagues, and also great to be with old colleagues, Konrad. So I come here, I'm a pulmonary critical care physician, so before I came to WHO, I worked in ICU and took care of many patients with sepsis who had very complicated disease courses, and it was really heartwarming to hear your presentation today, so thank you. And I think I want to congratulate the Global Sepsis Alliance on getting this far. It's been a long journey, and it's wonderful to see the 2030 draft agenda here and the strategic 5 pillars. So I think what comes to me first is, as you asked, what is our opinions on the 5 pillars? I see the importance of the nature in which it was developed. It's collaborative, it's multi-sectoral, it's interdisciplinary, and takes a holistic approach from the high policy levels, political leadership, all the way, and most importantly, geared on the patient. So I do think the patient-centeredness is key. The patient story is where we are going. So as we work towards this, always keeping the patient front and center, and the family and the community is really key. So I want to congratulate you on that. It remains sobering and humbling to see how many deaths we see a year and how many patients are still affected and families affected by sepsis. And so we must do better. I think that's the call to action, right? We must do better across different programs, right? Across different areas of the health system. across different stakeholders and wherever part of the stakeholder groups we're in to do better. So I think this is, again, a call to action to work together, to be collaborative. Many more brains are better working on a problem than one alone, and we've learned this many times and continue to learn it every day. So I think it is, I see it as a big call for action. The way I take it from the Health Emergencies Program, so I work in the Health Emergencies Program in the Department of Country Readiness Strengthening and lead the clinical unit there that writes a lot of norms and standards around clinical care issues during health emergencies. From our strategic documents that were published about a year ago, so there's a HEPR framework, it's Health Emergency Preparedness and Response Framework. We have 5 systems in that strategic framework, and I think it's important to align the sepsis work and see how much we can integrate sepsis into our strategic framework as well. It includes collaborative surveillance, we have a community protection pillar, we have a safe and scalable clinical care pillar, which is what I lead. We have a access to medical countermeasures pillar, and emergency coordination. So in that regards, we're trying to cover strategic pillars, similar but not, I could see many ways that we can integrate sepsis into our strategic pillars as well. In our preparedness work, the one piece that I saw missing from your slides was about getting sepsis incorporated into national action plans for health security and the joint external evaluation. So again, as we start to think about integration into UHC, integration into pandemic preparedness, integration into the NAPS may be another important thing to get sepsis highlighted. In regards to safe and scalable clinical care, I'm going to echo some things colleagues have already said, but I think it's important. Early recognition and treatment. I think this is really the cornerstone of getting the best, getting the best outcomes for patients and families if they have an infectious disease that may cause sepsis. So those early pathways are really important. I would also echo both the clinical and the diagnostics. I know colleagues from FIND are here. I know people interested in diagnostics. Can we do point of care testing to help better diagnose sepsis and also better tailor our treatments? I know we talk about antibiotics for bacterial pathogens, big need for antivirals for viral pathogens, but I do think helping us hone down that our colleagues from AMR, I don't know if they're here, where they are, but really taking a look at how much, what antibiotics are we using, how can we narrow sooner, and so really a call for diagnostics is really important. And I think our systems, like Teri said, our systems have to be ready to deal with endemic infections, right? There's endemic infections that are local, depending on where you live, what endemic infections you may be at risk for, and who are your at-risk populations, but get those pathways in place. And then that system, when there's a pandemic, when there's a new threat, when there's a new infection, can then surge to deal with that, and I think that really is foundational. So our WHO guidelines on clinical management are dealing right now with sepsis. The early phase parts of treatment is the first aspect of the guideline that will be coming out, and it's my pleasure also to talk about Jamie Rylands, who's not here, who works with Emily on co-coordinating that guideline function. A few threats on high-threat pathogens, because we spent a lot of time in the emergencies program focused on pathogens that have pandemic potential or epidemic potential. And I want to highlight the work there done on disease prevention and control, mostly under Maria Van Kerkhove now, who's the director there, and all the work that unit's doing. And then our unit that works specifically on the delivery of clinical care during emergencies and focuses on treatments. And also our infection prevention and control team led by April Baylor, that's focusing on keeping health workers safe during health emergencies as well. Our teams do focus on developing guidelines on pathogen-specific threats. So we have responsible for the COVID guidelines, influenza guidelines that will soon be published, dengue and other arbovirus guidelines also soon to be published, and also work on filoviruses and viral hemorrhagic fevers. And going back to some of the older diseases, vaccine-preventable diseases, because we are seeing a rise in those due to reduced vaccination in some communities, especially more fragile areas, working on measles treatments, guidelines, as well as diphtheria. Finally, and also when there is no, and I do want to emphasize the R&D component of the pillar, when there is no treatment, right, which we know a lot of these viral pathogens, these high-threat pathogens, there's not treatments yet. So we work closely in the emergencies program. We have the R&D blueprint, which is led by Dr. Ana Maria Henao Restrepo, who works on full-spectrum R&D for vaccines, diagnostics, and therapeutics for these high-threat pathogens. And we work closely with them on looking at novel therapies for pathogens. Before I finish, optimizing supportive care, critical care, I have to say how important is doing the basics well. And I think you also described that in the critical care services that you received at the hospital. And so our work, we've done a big intervention, big push on increasing access to medical oxygen on behalf of responding to the World Health Assembly resolution last year on increasing access to medical oxygen. Medical oxygen is a life-saving medicine, and what we're working on now is ensuring that national systems are able to integrate medical oxygen into their health system. And again, for all causes of hypoxemia, not just COVID, which was, I think, what kind of brought the attention to medical oxygen again to the world, but really for all causes of hypoxemia, including sepsis, especially sepsis, either pulmonary sepsis or non-pulmonary sepsis when you get acute respiratory distress syndrome and hypoxemia and need oxygen and many times advanced respiratory support. So that is an important project that we're working on right now. And then as Teri, also just to acknowledge the importance of doing clinical training on critical care to advance, to give clinicians and health workers the best tools to take care of their patients in all settings. So with that, I think I will stop. And just again, thank you so much. A pleasure to be here, and I look forward to working together.
Janet, thank you so much. We have absolutely brilliant contributions and feedback, and please be rest assured that we have the video recording. We will be taking notes of every single contribution. We will make sure that the draft narrative will integrate all comments from the different departments of WHO, and we really hope that this document will not only become the partnership and resource mobilization platform for GSA and our partners and the global response, but it can also align with the investment case for WHO and create additional financial resources, both for the World Health Organization's leadership in the area and the related global public-private partnerships. So this is something that we really hope can make a major breakthrough in sepsis, because we together shall make sepsis as the next success story of global health. And we have knowledge, we have evidence, we have data and potential. So thank you very much. Now it's my immense pleasure to hand over to my dearest friend and colleague, Dr. Eleanor Nwadinobi, President of the Medical Women's International Association, the oldest Medical Women's International Association. And I'm sure Dr. Eleanor will also acknowledge the presence in the room of our dear colleagues from the different regions of the Medical Women's International Association.
Thank you so very much, Mariam. Talking about acknowledging colleagues, I've noticed how, some of the previous speakers have wanted to have their bit of the claim to fame. So I'll start with you, of course, being our Secretary General of the Medical Women's International Association. But just ask my colleagues here from the Medical Women's International Association to give a wave and to show indeed what solidarity is all about. Thank you very much. Thank you. But who are we? The Medical Women's International Association is an association of female doctors. We've been in existence since 1919 with a focus on women's global health. And our triennial theme says One Humanity, Health Solutions through our partnerships. And a partnership such as you see today, where we are one of the partners in the multi-stakeholder dialogue, is something that, we're very proud of. Starting off with One Humanity. Yes, indeed, because disease does not know any geographical boundaries. Some of these diseases we're talking about today affect people who look like me. My first love as a doctor was as an anaesthetist, working in the intensive care and treating cases of septic shock. And I'm deeply humbled to be counted amongst one of several who have that opportunity to do so. Let me go quickly onto the role of MWIA. As they say, repetition is for emphasis. And discussing with my colleagues on the bus this morning, especially Elizabeth, a co-anaesthetist, and we said sepsis absolutely needs to be recognized in time for early treatment, including such as is given in the intensive care. So the training of healthcare professionals, of whom 70% are women, is essential. Research on sepsis needs to ensure that the differences between men and women are recognized for tailored treatment options and that they are better understood. We need the awareness and amplified voices of advocacy, the type of advocacy that MWIA is known for, with governments, with communities, with patients and survivors. So when we talk of awareness and appropriate response, in working with governments, we need to hear their loud and clear pinnacle of commitment. We need survivor-centered engagement and lived experience voices like yours, Krista. We need ring-fence funding. Mariam shared some sobering statistics today on the economic burden of not investing in sepsis prevention. Truly inclusive partnerships, not tokenistic ones, but inclusive partnerships. MWIA was glad to sign an MOU with the Global Sepsis Alliance to mark the International Women's Day this year on the 8th of March. Dear friends, we have an African proverb that says, if you want to go fast, you go alone. If you want to go far, you go together. May we, through these alliances, some of which we've seen today, indeed, go far together. Thank you.
Eleanor, thank you so much. And again, we're proud to represent 12,000 female physicians globally as the Medical Women's International Association. And we have in the room our vice chairs, vice presidents for Central Asia, North Europe, the president-elect of the Medical Women's, and also the CEO of the American Medical Women's Association, our treasurer. So thank you so much for your collective support and continued support, Eleanor. This means a lot. Together, we will make sepsis really the next success story, definitely. I have the pleasure of inviting our another strategic partner for the event, the Global Antibiotic Research and Development Partnership, GARP, represented by Dr. François Franceschi, the Serious Bacterial Infectious Project leader. François, thank you.
Thank you so much for the invitation. Since the time is not in our side, I'm going to try to be brief. Thank you, Mariam, because you put all the figures out there, so I don't have to repeat, how many people die from sepsis or anything like that. But I want to point out as another fact that, for example, in low and medium income countries, the incidence of healthcare-associated infections depending on the data you look at, is between 2 to 20 times higher than in high-income countries. So that's a big disparity. And some of that big disparity is not only because of the health system conditions, but also in part because you don't have the right antibiotics to treat those patients that have a severe bacterial infection that will end up becoming sepsis. And for example, from the, call it, again, this is a discussion always, but say if you look at the 25, in quotations mark, new antibiotics that have been approved since 1999, only 12 of those antibiotics have been registered in more than 10 countries, which is nothing. And then when you look at how many of those antibiotics are available in low and medium income countries, it's just appalling, the number. And so I mean, of course, to manage sepsis, we need desperately new and effective and safer antibiotics, but also we need to ensure access. And that's one of the critical pieces here, that in many places, I mean, some of these new antibiotics that target, for example, these really difficult infections like carbapenem-resistant infections that lead to sepsis, they are approved in high-income countries where the incidence is relatively low. But if you go to other countries where maybe the incidence is 30%, these antibiotics are just not there. So people is just trying to make all kind of crazy combinations. And that's essentially why our organization, the Global Antibiotic Research and Development Partnership, was created to provide support for the development of new antibiotics and also to provide access of these new antibiotics in the places where you really need them the most. Essentially, these are the two main components: accelerate and development, and facilitate and provide access. And we focus in two main areas related to sepsis. One is the multi-drug resistant bacterial infections that lead to sepsis, and also on neonatal sepsis. In neonatal sepsis, in fact, we are running, we are just going to start a trial of neonatal sepsis in 9 different countries, try to recruit about 3,000 babies to look at novel combinations of all antibiotics that could be used to treat neonatal sepsis more effectively than the combinations that are now being used, which in many places are not working anymore. So again, that's why a public-private partnership like GARP is key in tackling one of the major global disparities at the heart of the global sepsis crisis, which is this, disparity in access of effective antibiotics. And that's why we think that GARP is a critical player that could play an important role in the 2030 global agenda for sepsis. And essentially, we are here to provide all the collaboration we can into this. And I mean, at the end of the day, just as our previous speaker said, only together we can improve and end sepsis. Thank you so much.
François, we are grateful for continued support from GARP with Peter Bayer's leadership, who unfortunately couldn't make today, but thank you so much for joining us. And thank you for ensuring that the new strategy of GARP clearly highlights the importance of sepsis, especially neonatal sepsis. So we are already aligning our forces. Thank you very much. Now I have the pleasure of asking for intervention to the representatives of young medical professionals, the International Federation of Medical Students Association, represented by Lucía, Pérez, Gómez. And of course, when we speak about education and continuous medical education, engagement of medical students would be extremely important. Please, Lucía.
Should I? Yes. Okay. So hi, hello everyone. Good afternoon. I'm Lucía. I'm a medical student, and currently right now I'm serving in the International Federation of Medical Students Associations. So thank you very much for the invitation. It has been great to hear this panel, and also to see how we are planning. We're having a plan for 2030 to see how we can like work together to try to stop sepsis and to decrease the current data that we have. So like I have a look right now at the draft that you share with us, and like there are 2 or 3 points that I would like to point out. The first one is regarding the strategic pillar. In the point number 2, you talk about medical education, training, and how we are educated. And I think here is very important to also ask us as medical students and also as young people, how do we think and how do we feel with the current proposal that you have from your side. I think that this is something that we are always eager to reply and to give comments on this. I think that also in this moment that we are talking so much about digitalization, telemedicine, and digital health, we also need to focus and to put some efforts in low middle income countries. It's very clear that right now we don't have the same access and the same accessibility to internet and to digitalization in the world worldwide. We are, like we as Federation are represented by 140 countries, and we also feel this in our members. So this is something that we claim from all of us. More things that I think that are very important to tackle are the implementation, the capacitation of sepsis as a concept. I think that in the medical curriculum we talk a lot about, for example, like WASH, that was mentioned by some of you already. We talk a lot about IV fluids, but the concept of sepsis might not be so clear. And I think that given this data that is like really it's impactful to see. I think that we also need to start like having this concept more clear for us in our curriculum, and also to create awareness. Like EMR is being so in the media nowadays, because like also like it's posted in the social media, it's created awareness. Like young people is aware of EMR also because of the different campaigns that are happening on social media. And I think that this is something that we can also try to work on for sepsis, and also like to try to have like different like experiences as the ones that you share, like different patient involvement, not only like the healthcare professional, but also like the patient perspective. And yeah, I think that's a little bit from our side. I think that we can sit down in June and July to give more inputs and to discuss more about this. It's always good to be here as medical students, but also like as youth, to try to bring like a different perspective. I think that it's also very important to have youth people in the implementation and in the national action plans for sepsis, that hopefully will start to be like more and more, not only that 10% that you were talking about, but hopefully we manage to get more and more. And I think that is very important to also have some youth perspectives there. We are going to be the one in the front line very, very soon. And yeah, like thank you very much, and see you soon, I guess.
We definitely have the hope of the future with our young medical professionals backup, and I can promise that you will be listened to while we finalize the agenda, and it would be wonderful to have your active engagement. Thank you. We are joined today by the representative of Africa CDC, and regional and national centers for disease control are extremely important stakeholders in moving together the global agenda. And I would like to invite Dr. Mohammed Abdulaziz to the floor for comments and feedback on the 2030 agenda and our potential collaboration. Thank you so much.
Ladies and gentlemen, distinguished colleagues, thank you so much for inviting Africa CDC. And on behalf of the DG of Africa CDC, Dr. John Kaseya, who could not be here because of conflicting programs, I would like to say some little things about sepsis and the work we do in Africa CDC. The unit of infection prevention and control is in the Department of Disease Control and Prevention that sits in my purview. So sepsis represents a major public health crisis in Africa. our continent faces very high incidence and mortality rates from sepsis compared to the high income settings that we have here. An estimated 85% of sepsis deaths occur in low and middle income countries, with the highest burden right here, there in Africa. The most vulnerable population are children, pregnant women, and the elderly, who are disproportionately affected by this devastating condition. Of note, neonatal sepsis is a primary cause of neonatal mortality, with 99% of global neonatal mortality occurring again in low to middle income countries. The frequency with which newborn babies in Africa contract infection in hospital is alarming, and countries like South Africa found that infections acquired in hospitals were the largest cause of infectious diseases deaths in newborn. Almost 30% of babies contract severe infection while in the hospital in Kenya. The challenging health system in Africa do not always allow sepsis identification or antimicrobial resistance profiling, access to effective antibiotics, effective IPC skills and programs to facilitate prevention, sanitation and water, sanitation and hygiene, the wash facilities, to name a few challenges. For instance, in our data, it shows the low capacity and low performance of IPC programs at PHCs. And for us, the primary healthcare center is the nerve center of where majority of our population gets their healthcare needs. We cannot reduce sepsis in Africa without safe wash and IPC services at the PHC. This deficiency worsens the burden of sepsis across the continent. Without accurate data, our effort to combat sepsis are severely hindered, and evidence-based operational definition of sepsis tailored for African context is urgently needed for use by clinicians, institutions, and researchers and policymakers. First, African governments and major global donors need to work together to support investment to fund hospital infection prevention and control programs and national sepsis plan and infrastructure to strengthen health system. Africa's CDC was working with major partners to ensure IPC minimum standards are implemented in hospitals to reduce sepsis funding. Let me say clearly, COVID-19 showed something that we need to do on the African continent. IPC is usually seen as part of emergency response. It shouldn't be. It should be institutionalized in our institutions, in our hospital. You don't need to wait for emergencies to take IPC to the highest level and ensure that the best evidence is used for infection prevention and control. And this is what Africa CDC is trying to do now. Africa CDC IPC legal framework will empower countries to ensure safe and quality healthcare is available to all, urging national governments need to build infrastructure to ensure that every hospital has a reliable and clean water supply, strong IPC practice, and essential antimicrobials. Investment in programs that reduces infection in healthcare facilities will protect mothers and babies and reduce the burden of sepsis. Urgent action is needed to improve sepsis surveillance, IPC, research, and clinical care across the continent of Africa. Africa CDC is committed to working with partners to drive progress, leveraging the 2017 World Health Assembly resolution, engaging with WHO Afro to ensure a coordinated response. In our collaboration with Africa Sepsis Alliance, Africa CDC welcome an action-oriented partnership towards reducing the burden of sepsis, working with partners like the African Sepsis Alliance. Our shared vision on ensuring sepsis is recognized as a continental priority, collaborating to strengthen national systems through developing national action plans and generating data and research evidence from within Africa in improving IPC and WASH access to antimicrobials. This partnership will be instrumental in our fight against sepsis. In concluding, sepsis is preventable and treatable condition, yet it continues to claim millions of lives each year. Together, through collaboration, research, and targeted action, we can change this narrative. Let us work together to make sepsis a priority and save lives and build a healthier future for Africa and the world. Thank you.
Dr. Mohammed, we're delighted to hear your continued support from Africa CDC. And it's important to note that despite the fact that over 85% of sepsis cases are in low and middle income countries, and specifically sub-Saharan Africa, till today, we don't have any African country, except for Sudan in the emergencies, that has a national action plan or prioritizing sepsis in the national policy. So we have a lot to work, and thank you for this commitment. We look forward to the joint work. Now we are starting interventions from our dear partners from industry, private sector. And let me invite Mrs. Stacey Orsat, the President of Europe, South Asia, and Australia and New Zealand from Massimo, that is offering some innovative approaches to diagnosis.
Thank you, Mariam.
Stacey, please.
Thank you, Mariam. Thank you, Konrad. Thank you, everybody here. Thank you very much, Krista, for highlighting the lives that are alive and have endured sepsis, but also representing the lives that are not alive and the families that have been affected by sepsis. I'm very pleased to be here today. I am very fortunate to work with Massimo Corporation, who's been working on how we can improve lives and save lives and reduce the cost of care and improve outcomes for the last 35 years. But I also have had the chance to work with the Clinton Global Initiative. The first chance I had to work on improving lives together as MedTech was working with the Clinton Global Initiative to look at access to oxygen. Back in 2012, we started that conversation and started the Every Women, Every Child project to start with congenital heart defect screening, working together in the community, and then the United for Oxygen Initiative and Every Breath Counts Coalition to work on oxygen and medical diagnostics and screening. We are very committed to committing to the Berlin Declaration, and I'm here today to encourage all med tech companies to do the same. We have to work together in partnership. Science and technology must be one together, and it's very important that we commit on an action plan. So between now and September, to add to the strategic imperatives of the med tech commitment towards each strategic imperative, we can together make a difference. And looking at, for example, the AI side, and how can we together ensure, like you said, the sensitivity and specificity of data allows us to have awareness much earlier of the move of the human body towards sepsis, that intuition that you have that something is happening, to have data that informs that. But also how we can further prevent health issues and work towards health awareness in the community to manage health before someone moves towards an infection. There's so much that we can and need to do together. As medtech companies, we spend a lot of time on awareness, on marketing campaigns, on education in our manuals, on using digital tools. We can use those to create awareness to align with your agendas in your national societies, in your global societies, to create the same message and same campaign and align with those messages. So I encourage everyone to commit to do the same. The last thing I want to mention is specifically towards indexes. So Massimo's committed to bringing towards the data. So whatever data it is that you believe is important to bring together, we're committed to work with you to bring that data together for your access to use that. But to encourage the usefulness of data. It was mentioned about EMRs and the students being very well aware of EMRs, but how with the use of EMRs can we ensure the usefulness of data? So we're working on something called SI, or the sepsis index, but really geared towards the usefulness of the data, not just having the data. So encourage everyone to bring that data together, and we commit to being a part of that. The last thing I want to mention before leaving today is, of course, I work with Massimo, but I'm a mom. I work in my community. I go home and I volunteer, and I would encourage everyone who's listening and everyone who's here to not only take action with the hats we wear in societies or as doctors or clinicians or med tech people, but also as people in your community. Think of the one thing you can do in your town to talk about sepsis, to bring sepsis to your soccer club or your football club, or as a Canadian to your hockey club, to your community group. Make sepsis part of the regular dialogue, because we can, as individuals, all of our hats drive change. So thank you very much for having me here today, and I look forward to the action that comes next.
Stacey, thank you so much for being always so inspirational when we discuss the public-private partnership links that are essential for moving the global sepsis agenda forward. And as you said, at the World Sepsis Congress, there was a special presentation speaking about the strength and power of using the word sepsis. If we start speaking about sepsis in our families, communities, of course, this will add to the broader awareness. And as part of the 2030 agenda, we really hope that we can establish a global consortium or platform of public-private partnerships for sepsis-specific innovations and research. And this is something that we also look forward to exploring with partnership with Massimo and other stakeholders. Thank you very much. Cécile Barral-Baron, the Global Public Affairs Lead at Vaccine Sanofi, our new kind of partner whom we're starting to discuss the possibilities of prevention approaches, stronger prevention. Cécile, thank you so much for joining us today in person.
Thanks a lot. I'm delighted to be here today and part of this conversation. And I'd like to start by first, as many others did, thanking you and Mariam and the Global Sepsis Alliance for leading the development of this critical 2030 global agenda for sepsis and for inviting us to be part of the consultation process. The multi-year strategic plan that you presented is already very comprehensive, and congratulations for the work done so far in leading this work that has already led to many advances in the field of sepsis. You mentioned, so we are a vaccine company. So from a vaccine manufacturer and immunology company side, we would like to reflect on a couple of points from this draft agenda, building on what was said previously by some of the speakers. So the first thing we'd like to reflect on is the overall burden of sepsis. I think you presented rightly in the introduction that there is a tremendous burden on young children and pregnant women that definitely needs to be addressed. And in parallel, this was alluded to by some of the speakers as well, that there is another vulnerable population, and the global burden of disease studies show that there is a second peak in sepsis incidents in older adults, and we believe that it could deserve to be mentioned in the draft agenda, and linked to that is the older adult health as a component to be considered in the health system readiness pillar. Secondly, is that we are convinced that prevention through immunization is essential in the response to sepsis, as any infection avoided is a potential sepsis case avoided. And we are fully supportive of the integration of immunization in this 2030 Global Agenda for Sepsis, already present across the Pillar 2, 3 and 4, with the call to set ambitious vaccination coverage rate, both for childhood and adulthood immunization, the call to implement routine immunization in the community, and on the R&D piece, the call to advance the R&D for novel vaccines targeting infections leading to sepsis. And what we want to build on is that moving forward, we think it will be very important and critical to have this prevention and immunization component really reflected and implemented into the national action plans. Another point is building on the data gap that was commented by some of the speakers already, is that clearly improved surveillance is an important foundation that will definitely support the prioritization of sepsis in the health agenda and as well the appropriate response it deserves. And so we think we need more connected and more comprehensive surveillance system to perform global monitoring, to support the early detection, to better understand the pathogens and as well the individual characteristics leading to sepsis, and as well to better document the impact of sepsis on the healthcare systems and as well on the quality of life of the sepsis survivors and the families, carers, and thanks a lot for the testimony you shared earlier today. And one of the last points is building on this interconnection between sepsis and AMR. So clearly the multi-drug resistant infections leading to sepsis are representing a significant proportion of sepsis cases and are adding a challenge in the management of this case due to the AMR. And building on this interconnection between AMR and sepsis, we think that leveraging the synergies to advance both agendas in parallel definitely needs to be continued and reinforced, including as well for the prevention component, as the fight against AMR will help the sepsis response and vice versa. And underlying this point is the importance of raising awareness, continue the advocacy effort. And so we are fully supportive of this need to reinvigorate the global action on sepsis And we'll make sure that we can bring our contribution, both in the definition and in the implementation, where and when it's relevant. So thanks a lot again for having us here today, and looking forward to the next steps.
Cécile, thank you for highlighting the importance of integrating vaccination and prevention strategies. Definitely, GSA has been behind the model NAP frameworks, and so we will definitely update. We will kind of refine the existing templates for national action plans, and we can reflect as many suggestions from the floor as possible. And of course, we look forward to discussing more as we move forward with finalization of the document. We have today here with us another representative of GSA partner organization, Abionic, Dr. Iwan Märki, the Chief Technology Officer and co-founder of the organization. And yes, please. And we're grateful for the former CEO of the Abionic, who is currently the CEO of the Biotech Campus, Nicholas, for his continuous support.
Thank you for the invitation, and thank you for all the efforts made to align the understanding of sepsis and the cause of sepsis. We can definitely recognize these efforts when we go to clinicians or when we go to regulators, where we can see that this understanding is being aligned more and more. We can still see that the definition of sepsis is not so easy, and we can still see differences among clinicians and, in the definition of sepsis. And also the regulators, we can see there, we recognize that there is some urgency among them, but some of the notions of how to tackle the understanding of sepsis is still difficult. We have been talking about early recognition of sepsis being as a key of fighting sepsis. But what does it mean, early recognition of sepsis? As a manufacturer of in vitro diagnostic tests with a biomarker for sepsis, we have been focusing on this topic, and it was and is not an easy topic. Early recognition of sepsis. Does it mean to identify sepsis before clinical symptoms? Ideally, yes. At establishing a tool to identify sepsis earlier than the clinical symptoms, it is very difficult because the notion of predictive value is not very present among clinicians and among regulators. Establishing or defining a clinical study with endpoints that allow us to clearly prove or show the performance, the clinical performance for biomarkers or tools in general to identify sepsis earlier before symptoms is not easy. And this is something that we are working on. And I think if we can work on that notion of how do we identify that very clearly in clinical studies and with clinical tools to identify sepsis early, then that will help us to treat better, help us to decide on giving antibiotics or not giving antibiotics. And we have been working on that topic in the last 5-6 years with our new biomarker, which has a predictive value, and where we have already seen fruits of hospitals that came back to us, giving us very beautiful stories of patients that have been flagged or that have been identified that there is an issue and that have been treated earlier and that they could save these patients. And that is what motivates us to go forward, and that motivates us also to contribute to this community and to work together with you. Thank you.
Early detection, early identification and treatment, of course, those are the game changers of the sepsis fight. And we look forward to partnering with Abionic and other strategic partners from industry, because it's only jointly through public and private partnerships that we can truly overcome the unmet needs in diagnostics and treatment and save millions of lives and, of course, reduce the financial burden. Unfortunately, because of the continued kind of flow of interventions, Professor Kevin Otterson, founder and executive director of CarbX, he had to leave for the assembly parallel session, but we're extremely grateful for his participation, and we look forward to continuing work with CarbX on how we can join forces. We are also joined here by Saza Ibrahim, the representative of the Clinton Health Access Initiative on behalf of David Ripton, and we thank our dear friend and colleague, the Executive Vice President of CHAI, for his continued commitment. And as the last intervention from our partners, I would like to, but not the least, definitely, I would like to invite Dr. Ghada Zoubaine, Head of Partnerships and Stakeholder Engagement of International Center for Antimicrobial Resistance Solutions. Dr. Ghada.
Thank you very much, Mariam, for extending the invitation to ICARS. So ICARS is the International Center for AMR Solution. It's the new kids on the block, 4 years old. That's a little toddler growing. It's an initiative that's been initiated by the Danish government. We are now governed independently and as such able to attract a range of donors and funders. And what ICARS does is it recognize the fact that when we're talking about AMR, the burden of antimicrobial resistance, many of the low middle income countries really are the ones that feel the burden because of low resource setting, because of competing priority, and there are so many other things other than AMR that they need to worry about. And the way it is as well historically that a lot of the evidence that have been generated either have been generated in high income country, and there is an assumption that those evidence will actually be implemented very automatically in some of the setting, or that some of this evidence have really got stuck in the scientific community and may not have made it more into policy and implementation. So ICAR's role really is to work in a, what we call top-down, bottom-up approach, working with ministries in low-middle income countries, as well as the research community, civil society, patient representation, which is really within the relevant location. All the solutions that are tested in the context have to be really relevant to the social and cultural context that it's in, have to be owned by the country. So ICARS doesn't come with call for proposal saying we want to fund this. It will say what does the country need and how we can actually help shape up and support some of the effort there. And very importantly, it has to be informed by intervention implementation research. It was mentioned by you, Mariam, I think earlier on, in many cases we do know what the solutions are, but sometimes testing them and what we call implementation science is considered not very sexy science for many people. But the reality is this is what is really needed, because unless we test certain solution and know how it works in its setting, it's going to be very difficult for us to understand how it works. During COVID, social distancing in Switzerland was definitely different from my home country in Lebanon. And the 2 meters suddenly becomes, you know, like 30 centimeters in Lebanon and 3 meters in Basel. And that's because there's a lot of cultural aspect that we bring into solution in countries. Why are we in this meeting? Because everything that Mariam have presented here, and all of you esteemed knowledge people in sepsis, really we hear it in AMR. So there is a lot of cross-cutting effort that unless we actually come together, it's going to be very difficult to keep on advocating for the same things from the same stakeholder and politician who probably don't have too much time to hear there's so many problems in the world, right? So they need to prioritize. So we're talking about IPC, we talk about research and development, we talk about stewardship. These are common causes that between sepsis and AMR, it really needs to come together. And very importantly, capacity strengthening, because country really, in many countries, it's the same person doing sepsis, the same person doing AMR, amongst a million other things. So we are so happy that ICARS currently is in over 20 countries and with 40 projects. So a toddler that has delivered okay during COVID. Of course, we have Georgia, one of the earliest country that we have. Very proud of the work on stewardship that we have done in hospital there. And it's been really a nice success story that the country themselves want to roll out some of these stewardship tools that have tested into their setting. Other country like Kyrgyzstan, we didn't anticipate the success of the uptake of diagnostic for respiratory infection for the under 5 and how that has informed better stewardship for the children. I think some of these little pilots that we have done can really inform how we work more effectively in countries. And when we are in countries, it's definitely effective to align the agendas, both for sepsis and AMR. Thank you very much. Thank you for all your effort on sepsis and looking forward to partnership. Thank you.
Thank you so much. I mean, the highlights of AMR and essential and critical synergies between AMR and sepsis, that is something that we definitely have to continue and look forward to working with ECARS as we move forward. Before my concluding statements, there is another announcement that my dear friend and colleague, the CEO of the American Medical Women's Association, Dr. Eliza Lo Chin, would like to share with us, and let me ask her for her remarks.
Thank you so much for just a few minutes on the podium. Like this? Okay. We're thrilled to be a member organization of the Medical Women's International Association. I currently serve as the treasurer. And we have 2 wonderful events we just wanted to let you know about. Tonight, from 7:30 to 9 o'clock, there's a special screening of the film Afghan Dreamers. It's a film about the Afghan girls robotics team, very inspiring about their journey and how they overcame so many obstacles. And of course, in light of what's happening now in Afghanistan, even more poignant, their story. It's going to be followed by a discussion with one of the associate producers and also an Afghan woman physician. And then tomorrow morning, we have a roundtable. Again, this is hosted by both MWIA and AMWA. The roundtable is going to be focused on the role of women's leadership in advancing gender equity and workplace well-being, and that's going to be from 10 to 11:30 in the morning. Both events are going to be held at the Nash Pratique Hotel at the top floor. We've got some flyers that are being passed out, and maybe we can follow up by email with some of the links. So thank you so much for this time.
Thank you, Eliza. And of course, Medical Women's International Association is part of this big partnership, and including the American Medical Women's International, along with 41 other national associations of medical women in the world. And let me also highlight that next year we have a major triennial International Congress of Medical Women coming up in Egypt, Cairo, and with agreement with the President-elect, Dr. Amani Asfour, we can proudly announce that the scientific session of the Congress will include sepsis among women and children. And of course, we invite you to become part of the community, part of the partnerships of medical women, the Global Sepsis Alliance, the CHAI, Unite, our dear Sepsis Stiftung colleagues, for really joining forces and making the 2030 global agenda for sepsis a reality. And with today's meeting, starting with the amazing intervention from Krista, with the commitment from the key decision makers from the World Health Organization and our strategic partners, I'm more confident than ever, and participation of our private industry partners, academia, international associations, that sepsis can really become the next success story of global health. We've seen how the success stories have been led, and we learn from the experiences, both from positive and from the lessons learned. And I think that we have an amazing potential and an amazing journey ahead of making sepsis success a reality. I'm immensely grateful for each of you for staying for this rather long discussion and for your contributions. And thank each of our colleague, friend, and partner of the GSA for following up through the live stream, and we look forward to continuing discussions and finalizing the first multi-year strategy for the global sepsis response. Thank you once again.